My name is Michaela. I am one of the current third-year ID fellows, and I'm happy to be here today, talk to you guys about some common outpatient ID cases and some antibiotic tips, hopefully give you a couple strategies going forward. So just a few things. I was a prior resident here, and my continuity clinic was at the International Clinic. So for any of you, if any of you are the International Clinic folks, you guys are in for a lucky, awesome continuity clinic experience throughout residency. And now I'm at Madison Clinic, so probably see a couple of you rotating through there as well. I know some of you have your continuity clinic there as well, so hope to see you around. And I'm around and happy to answer questions about ID fellowship and all that kind of stuff. All right, let's get started. Just going to go over some common things today. I do not have any disclosures. This is going to be kind of a case-based format. We have a few polls, but feel free to unmute yourselves, ask questions, type them in the chat. I'll try to keep an eye on the chat box, and we can go from there. We'll have 4 cases today. So these are not diagnostic mysteries. These are all mostly management cases. So if you right away know the case, hopefully that's a good thing. So starting with case 1. So this is a 20-year-old woman who comes into the clinic with 2 days of pain with urination and increased urinary frequency. She's sexually active, but she has no fevers, chills. Her only medication is oral contraceptive pill. She has no allergies, and on exam, she's afebrile with stable vitals, no flank pain when you talk with her. So we're thinking about UTIs in this lady, but I think before you just jump to easy UTI diagnosis, I think good thing to keep in mind is just what's the differential for UTI and what other things should be in the back of your mind that you're thinking about with this patient. So in women, you should be thinking about vaginitis and urethritis. Does she need STI screening? Men coming in with UTI symptoms, although that's much rarer, STIs should definitely be on your differential for those folks. So talk about their sexual history. And then also in her, should you be thinking about pelvic inflammatory disease? And that might have you ask a couple more history questions. You know, is she having any vaginal discharge? If you're doing a pelvic exam, if you feel like based on some of her history symptoms, a pelvic exam is worthy. Does she have cervical motion tenderness on exam? Does she have mucopurulent discharge? And then anytime we're moving into treatment and thinking about treatment for these things, this is for all ID. We like to think about what organisms we're trying to cover before we just blatantly or quickly choose an antibiotic. So UTIs are far and away caused by the GI bugs and especially the bacteria at the vaginal flora. And so E. coli far and away is one of our most common offenders. So you definitely want to be covering E. coli. And so what are your symptoms of cystitis? So you want to ask about dysuria, urinary frequency, urinary urgency, suprapubic pain, and even some people can have some hematuria. So that, no, that's not as common, but that's definitely a symptom that we see. I just wanted to reframe UTI just to keep everybody on the same page. I know there's, complicated versus uncomplicated approach. I like to just break it down into cystitis or pyelonephritis. Are we thinking about cystitis, which is an infection of the lower urinary tract system, or are we thinking about pyelo or a more systemic illness where there's an infection of the upper urinary tract and the kidneys are involved? Those folks are presenting with fevers, chills, flank pain. They often have other signs and symptoms of sepsis. And just my plug, but especially in the outpatient setting, in the inpatient setting as well, we treat and think about UTIs very strongly based on the symptoms. Urinalysis, or UA, can be helpful in ruling out a UTI, but I'm not looking for, must have LE, must have nitrites, those kind of things. I'm not looking to kind of find the perfect combination of the UA to diagnose someone with a UTI. So I'm really just hearing their history, talking about their symptoms, kind of asking history symptoms that rule out other things and trying to figure out, are they having systemic symptoms at the same time? So don't be overly dependent on the UA, and definitely don't just treat a UA for with someone who's not having symptoms. We'll get into the nuances of that right now, actually. So here are some groups that you want to have some special considerations for. So in older women, a lot of older women have a lot of UTI-like symptoms at baseline. So you really want to think about a change in symptoms. So, you know, are they having new incontinence? Are they having increased urinary frequency? Things like that. So someone who may have some kind of baseline UTI-like symptoms, really want to focus on a change in symptoms. For men, men can have uncomplicated UTIs, believe it or not. But if a man is coming to me with UTI symptoms, you want to think about other causes, something that may be complicating the picture. You know, are they having obstruction? Thinking about BPH, if there's a stone in there. Thinking about, especially if they're having recurrent UTIs, say you treat them for the shorter course, they're coming back pretty soon. You want to think about prostatitis in those in those gentlemen. So chronic prostatitis can be an issue that we run into, and that just changes your duration of your antibiotics as well as which type of antibiotics, because you want to make sure you're penetrating the tissue that you need to get to and not just concentrating your antibiotic in the bladder. Pregnant women and kidney transplant, there are patients who've had a kidney transplant. Those are two patient populations in which you are treating asymptomatic bacteriuria. And in those patients are just at higher risk for complications, even if they are not having any symptoms. If they have bacteria and bacteriuria, we treat those folks. So patients who have had kidney transplants, really just during the first 3 months after transplant, and otherwise they go back to being treated in this way like everybody else. And then a special kind of Harbor View patient population shout out. So for PWID, or patients who inject drugs, if you are getting a urine culture on them for another reason, say they're fevering or things like that, and their urine culture grows MRSA, that's someone you want to think about a systemic infection. We do not see Staph aureus in the bladder in someone who is not catheterized. It can be a colonizer, but in someone who's not catheterized, if Staph aureus grows in the culture, we think about that this might have gotten seeded from somewhere else. So especially in your in folks who are injecting drugs, we would be worrying about bacteremia, endocarditis, those kind of things. That should trigger you to kind of do a reflexively more broader workup of where that staph is coming from, not one of our typical UTI bugs. Okay, so with that background, we come to our first poll question. So you're worried this patient has a lower UTI. Which of the following are first line treatments for cystitis? You want to choose all that apply here. And I'm seeing the votes trickle in, but again, choosing all first line agents. Waiting for a couple more of you here.
Is there supposed to be a poll that's supposed to pop up?
Yes, are folks not seeing a poll? Most people have voted.
I'm not seeing a poll.
Me too.
Oh, interesting. Can you?
Now I see it.
Okay, all right, when you relaunched it. Thanks, Whitney. Sorry for those of you who already voted, if you don't mind punching in your votes again. Thanks for unmuting. I'll just holler if there are any technical glitches like that.
I still don't see. Oh, I see it now.
Okay, great. All right, I'm gonna stop it. I'm gonna stop it there. All right. Hopefully you can see the results here. So we've got answers all across the board, which is great, with the most common answer being nitrofurantoin. So we are gonna go through the first line treatments here. So here are your 3 first line treatments. So we've got trimethoprim, sulfamethoxazole, or Trimsulfa, which brand name is Bactrim, nitrofurantoin, brand name is Macrobid, and fosfomycin. I bring up the brand names because you're going to hear them a lot, especially, and patients may come to you and speak to you in those terms, but we'll try to use the generic names as we can. So these are the IDSA guidelines for a treatment of acute cystitis, and I'm going to highlight a few things on here. So your first line agents are highlighted in blue here, and those are nitrofurantoin, Trimsulfa, and also fosfomycin. And I want to highlight on the right side, I did put the doses in duration, and no need to memorize the doses. These are always things you can look up. But I just want to highlight the length of the doses. These are short courses, and I think a rule or an ID thing that is trending in ID and continues to trend, the more data and more studies that we do, is that shorter durations of antibiotics are generally better. And that is for the majority of infections, with a few exceptions of things like osteomyelitis and endocarditis and those kind of things. But if you're choosing between 2 durations for common infections, generally the shorter ones are safer. So no need to be doing week-long treatments in these folks, that kind of thing. Even longer in other folks. So these are your first line agents, and I will kind of walk you through how I think about treating folks and choosing between these. And as you can see, fluoroquinolones are second line, so your Cipro and your Levo, and I will talk a bit more about those as well. So this little asterisk for Trimsulfa. The caveat to the first line treatment there is that if your local E. coli resistance to Bactrim is greater than 20%, then you should be, instead of considering Bactrim, then you should choose a fluoroquinolone. Most people don't go around knowing their local E. coli resistance to Bactrim, but as an ID fellow, this is something we do see and come across. And if you look at our inpatient antibiograms, that is actually us. We have a higher than 20% E. coli resistance to Bactrim. And so we would fall into that category. I put a star there because our inpatient patients and the antibiogram that they have created that we look at and use is going to be different than our outpatient antibiogram, which they're currently working on, but we don't have at this point. And so I want to say in the patients that we have, the patient like in this case, who's a young woman, otherwise healthy, no comorbidities, doesn't live in a skilled nursing facility, or it doesn't have a lot of frequent hospitalizations, I think you could feel comfortable prescribing her Bactrim. In this situation, you wouldn't have to jump to a fluoroquinolones. Fluoroquinolones have gotten a bad rap recently and kind of deserved. There are a lot of black box warnings that keep coming out on them, and so we try to save them for that purpose. We don't want to give people side effects to antibiotics when there are other options available, but also because fluoroquinolones are a bit more broader than you need here. And so if one of these other options work, then I think it's safe to go for that. So here's how I think about it in order of things I'm considering. And this is for men and women, by the way. Like I said, men can have, in some circumstances, uncomplicated cystitis. If they do, these agents work for men as well. The durations, maybe you add on a couple days, but again, short durations in men for uncomplicated UTIs are also work just fine. You just want to be sure you're thinking about ruling out things that would make them complicated. So nitrofurantoin, that would be my go-to choice for folks. It's well tolerated, it concentrates in the bladder, people do really well on it, short courses. That would be my go-to treatment for acute simple cystitis in the outpatient setting. My second choice, I would kind of choose between Trimsulfa or Cipro or ciprofloxacin. And I would try to figure out what are my patient characteristics. Is this person going to be more at risk for resistance? You know, do they have that skilled nursing facility history? Are they in and out of the hospital a lot? Have they had resistance before? Or maybe they have an allergy to Trimsulfa or Sulfa. So those kind of things would push me more towards Cipro. But otherwise, I would use Bactrim when I can. The fluoroquinolones we also try to save for people who are having pyelonephritis and more systemic infections, because they get into the kidney as well. They're excellent agents at treating systemic infections. So we try to protect them and save them for that reason, and also the side effect, complicated side effect profile. And then my third go-to is fosfomycin. And that is awesome, and that is just one dose. It's like a powder, you mix it into water and you just take it once. The reason I have that third here is because there have been some studies that show some increased recurrence when using increased rate of recurrence when using fosfomycin, but also it's actually an awesome antibiotic, and we try to save it for folks who have MDR UTIs, and it is one of our few. It can have a fairly broad spectrum, and we kind of keep it in our pocket for folks who have all these crazy multi-drug resistant organisms and have difficult to treat UTIs. So that's my order of how I'm treating them. And I just avoid, beta-lactams are more than you need in terms of broad spectrum, and don't do as well. And then when to get a culture. For acute simple cystitis in women, you do not need to get a urine culture. You don't really need to do much of a lab workup. I would attain a culture if you treat them initially and their symptoms don't resolve. If they have risk factors for a multi-drug resistant infection, maybe you can see in their prior cultures that they've had a history of these, of an MDRO, they live at a skilled nursing facility, those kind of things. If you're worried at all about complicated cystitis, I would get a culture. And then those special populations, your kidney transplant recipients, those kind of folks, you're going to want to know what their what organisms are causing trouble in them. And then the only follow-up urinalysis I would get in normal cystitis is if folks who have hematuria. You want to make sure that clears. So I would get a follow-up urinalysis for those folks. So take-home points for UTIs. First-line treatment for cystitis, I would go nitrofurantoin first, then to your trim sulfa, consider fluoroquinolone like ciprofloxacin as number 2, and then fosfomycin as number 3. Symptoms are more important than what the UA shows. And on the inpatient side, patients with catheters commonly get colonized. So for your random altered mental status patient who, you know, is slightly more altered today, you're just sending you a UA off to try to figure out what's going on, that's going to grow something. So catheters are going to get colonized. Don't be surprised by that. That does not mean they have a UTI. And then the asymptomatic bacteriuria folks, we are treating pregnant women and early renal transplant recipient patients. Great. For those of you who are into podcasts, actually just yesterday, the Curbsiders, there's an internal medicine podcast, had a UTI, an episode on UTIs. That was, I thought, very well done from a fellow at Emory. If, you know, this wasn't enough UTI knowledge for you, for you today, definitely worth checking out. Moving on to case 2. Kim has a question. I have never ordered a repeat UA for UTI hematuria. Yeah, it's recommended in the guidelines. I think you can kind of do a little bit of a judgment call. Even with young, otherwise healthy women, I think your concern is going to be low, but I think you just want to make sure, like, their UTI their hematuria should have completely resolved, and you want to make sure that they're not having ongoing hematuria for something unrelated that just presented at the same time. Thanks for that, Kim. All right, we are going to move on to case 2. This is a 48-year-old man. He has a history of diabetes, came to clinic with 5 days of redness, pain, swelling over his left shin. He thinks he may have scraped his shin a few days prior to developing his symptoms. He has no fevers or chills. His most recent A1C from 4 months ago was 8.6. On exam, he's got stable vitals. His left shin, he has a large area of erythema. It's warm and slightly tender to the touch. And he has, there are no areas of fluctuance or drainage. So what are we thinking about here? We are thinking about cellulitis, right? I just want to put in my plug. All red legs are not cellulitis. You would be shocked at the number of folks on the inpatient side who are consulting ID for cellulitis, and we've seen it all. Bilateral cellulitis on the cardiology team and all that kind of stuff. So think about what's your differential for this person. Could it be contact dermatitis? Could it be venous stasis dermatitis? Do they just have venous insufficiency that's leading to the redness? Is it a DVT? Are you thinking about, they have risk factors for lymphedema? And just another plug, bilateral cellulitis is exceedingly rare. And if you're seeing it equally on both legs, you may want to rethink your differential. Getting back to our bugs, thinking about our bugs first. Strep and staph are your common causes of SSTI. So you want to think about covering strep, covering staph. You know, MRSA is going to be a little bit less common than just your general MSSA. Then it's your Pseudomonas, GNRs, anaerobes. And then, you know, most rare thing, though fun things that we think about are your least common causes, Ehrlichiosis, Vibrio, Mycoplasma, those types of things. In the outpatient setting, what you don't want to miss, because it's a surgical emergency, is NSTI, or necrotizing soft tissue infection. So these patients are also going to present with erythema, edema, and pain on their legs. But things that are going to put you off, or put you more towards considering an NSTI, they're the severe pain out of proportion to exam findings. So, you know, maybe their leg looks a little bit red, but when you go to examine it, they are jumping off the table. They do not want you to touch it. They're having systemic symptoms like fevers, maybe some hemodynamic instability. And then when you're examining them, they might have crepitus at that area, you know, so you're feeling some potential gas under the skin if it's well advanced, or bullae, again, if it's far along, these folks can develop bullae. And again, this is a surgical emergency, so these folks need to go to the ED and they need a surgical consult immediately. Antibiotics is not going to be their answer. This is a very advanced case of an NSTI. Just so you know what these like hemorrhagic bullae look like. This guy presented very late. He had a history of injection drug use in that arm, and unfortunately, he lost his arm from that. So antibiotics aren't going to get you there. Talk to your surgical colleagues, but just something to have in the back of your mind when you're seeing these folks as an outpatient. Okay, on to our second poll question. Let me know if you're having issues seeing the poll. Which of the following oral antibiotics cover MRSA? And again, this is going to be more than one option on here. All right, going to give you about 20 more seconds. Okay, great. I can already tell you guys had much different responses than the first intern immersion block, so I can tell those of you who've already hit the wards, I've picked this up quickly. So here are your answers here. You've got trimsulfa and doxy with the highest results, and then clinda and linezolid, and we do see some vanc on here. Vanc is a little bit tricky because, oh, sorry, let me show you your results. Now you can see what I'm talking about. I did say oral antibiotics, and vancomycin is not oral, so that was a little bit tricky there, but otherwise, these are all correct except for augmentin or amoxicillin clavulanate, the first choice. That does not cover MRSA. Okay, so moving through here. So again, to highlight, trimsulfa, doxy, clinda, and linezolid. And I'm just going to briefly touch on our antibiogram. I think this antibiogram, I hate to say it, but is worth memorizing. You are always, in the inpatient and outpatient setting, you are always going to need to know, one, do I need to be covering MRSA? You know, is MRSA a risk here? And two, am I currently covering MRSA with the antibiotics I'm choosing? Oh yes, so Alex Torres mentions PO Vanc for C. diff. So there is PO Vanc, thank you Alex, great point. But as you are aware of, as you were pointing out by putting it in there, it does not have systemic absorption. So it just stays in the gut of the in the lumen of the gut, which is why it works well for C. diff. But we are never treating MRSA that way, and you're never giving oral vanc for MRSA. So great point, Alex. Thank you for that. Yeah, that is the only indication for oral vanc is C. diff treatment. So coverage on the oral options are on your left. I just like to point out the percent sensitivity that that MRSA has to these organisms. So trimsulfa and doxy hang around the high 80s, low 90s in terms of sensitivity. Clinda is really 50-50. I want you to know that that does have some MRSA coverage. We do not use that as a go-to MRSA coverage, and really unless you have your sensitivities back and for some reason it works. For those of you who have kids or remember from peds rotations in medicine, pediatrics uses Clinda for MRSA coverage all the time, and their antibiogram is very different, and they actually have great MRSA sensitivity with Clinda. So that may come up in your lives at some point. And linezolid is 100%. It's now generic. We do reserve it a bit and use it less commonly because it's hard to give long courses with it. It has the bone marrow suppression and some other side effects that don't work well with long courses. And also it's another antibiotic that we are trying to protect. On the right, just to briefly touch, I know you guys are in and out of the wards as well. You know, vanc has excellent MRSA sensitivity. It's 100% at our hospitals. There is vanc resistant Staph aureus or VRSA, VRSA. We have not seen a case here. And then you have daptomycin, ceftaroline, the new 5th generation cephalosporin, which has a coverage of ceftriaxone plus MRSA coverage, essentially. And then dalbavancin, which is the long-acting one that you need an ID consult for, but lasts for a week. So my only highlight on this is that as we're thinking about what choices we're going to cover for cellulitis, Bactrim or trimsulfa and doxycycline are not sufficient empiric monotherapy for cellulitis, for purulent cellulitis, because they don't have great strep coverage. And again, if we go back to that pyramid of organisms, strep is going to be so common. So even if you are worried about MRSA and you're thinking that this is a more purulent cellulitis and you want to cover staph, both MSSA and MRSA, you can use one of these agents, but not by itself, because you still want to cover strep, just given how common it is, and they don't have great strep coverage. So here are the IDSA guidelines in terms of treatment for skin and soft tissue infections, or SSTIs. So this is kind of divided as non-purulent and purulent. These rule of thumbs still stand. I know people question them a lot, but non-purulent cellulitis, your classic just red erythematous skin that's painful, that suggests strep. And here the options are penicillin, cephalexin, which is also Keflex, clindamycin, and then dicloxacillin, which we have on formulary, but it's the same spectrum as cephalexin, and we just don't really use it as much. There was a randomized control trial in 2017 that said that there was no improvement in clinical cure when adding Bactrim to a cephalosporin for non-purulent strep. So if it's non-purulent, you can go with your monotherapy of cephalexin or whatever you choose. And for non-purulent cellulitis, you don't need to add Bactrim empirically. For purulent cellulitis, that suggests staph. These are folks that if you're able to do an incision and drainage and drain the pus, that's incredibly helpful. And you can send that for culture. That can help guide you. We can do sensitivities on that. And your guideline recommended treatments for that are either trimsulfa or doxycycline. So you get that MRSA coverage. So again, here now the guidelines with my takes. So for non-purulent skin and soft tissue infections, I just go with cephalexin. It's well tolerated. It's annoyingly 4 times a day, and I don't think anyone can take a pill 4 times a day, but I swear people probably get in 3 times and do just fine. You didn't hear that from me. That's not the official dosing recommendations, but I think it's a great option and tolerated very well. And then for purulent cellulitis, I choose in between, either based on you know, if they have an allergy to trimsulfa or kidney disease or things like that, maybe that pushes me more towards doxy. But either of those work really well. So just remember that when you're doing purulent cellulitis treatments, you need to add cephalexin for that additional strep coverage. Great. And so right as Seifu asked that question, right as I was saying that, that if someone has purulent cellulitis, Bactrim or doxy is not enough. You need to do Bactrim and cephalexin, or doxy and cephalexin to continue strep coverage. Thank you for that clarification. And Kim, yes. I see you said never mind your question too. But again, if you're worried about MRSA, you should still be covering for strep, and those folks are going to get both or 2 antibiotics. John saying, do we ever just do an ID without antibiotics for purulent cellulitis? Yes, you do. So the indications for just IND alone with no antibiotics are for folks who have, I believe that the abscess size is less than 5 centimeters. So pretty small, but if someone's coming in with a 5 centimeter or less abscess, you can just IND it, drain it, and they don't need anything. So thank you for that. As the ID fellow, I should be highlighting areas when we don't need antibiotics as well. And they obviously have to be otherwise clinically stable and things, but 5 centimeters is pretty small. So I feel like by the time folks present to you, oftentimes they're in a little bit more, the issue is a bit more bigger than that. Yeah, so Safe is saying up to date says Bactrim is enough for purulent cellulitis. I wanted to clarify. Welcome to the confusing cloud that is up to date. These are the IDSA guidelines, and I think, which I would go to more, and I think the issue is you have to be pretty darn sure that that purulent cellulitis is just staph. And if you don't have any culture data to guide you, and depending on how severe the patient is, you know, you are not covering strep at all. And so I would send that patient out with both trimsulfa and cephalexin to make sure that you have the strep coverage as well. So yeah, no problem. All right, crew. So just to go back to the case, I just wanted to highlight the things that pushed us there. The guy was very stable. It looked like a non-purulent cellulitis. So I would prescribe this gentleman cephalexin for 5 days. Again, short courses, people tend to do really well. You don't need your 10-day course for cellulitis, you know. On the inpatient side, you know, maybe their first couple of days are IV up front, but again, 5 to 7 days is really all you need. No need to push it. Takeaways from our cellulitis case. Okay, so Kim is asking, people with a history of MRSA infection, does that change what you do? So for skin and soft tissue infections, yes, I feel like that makes you maybe in those patients, even with non-purulent cellulitis, maybe you would also want to cover MRSA as well. But I think it would just push you to cover MRSA in addition to everything else, but again, not solely cover MRSA. But I think if their NARAS swab is positive, that's likely an indication that they're colonized. And so I think this is a good time when we would use that to kind of guide, make sure they have MRSA coverage on board. Bree says, if non-purulent SSTI not clinically improving, when do we broaden coverage? Yeah, so I think you give them a shot. You know, I would give them the full 5-day course trial to see how they're doing. I'm assuming this is in the outpatient setting, and you could either just talk to them about return precautions and when to call you or contact you, whether via e-care, or if you're worried about them, send yourself a message to call them in 5 days and see how they're doing. They may need to come in. We don't see a lot of strep resistance to cephalexin. So I think if they were not improving, it might be more of an issue. Do they have any reasons why they wouldn't be absorbing it? Are they having diarrhea at the same time, or is something else going on? So in SSTIs and things like that, those are rapidly spreading, rapidly developing toxin-mediated issues. So that would be word on that. Otherwise, I would, if they're clinically stable, I would start to rethink your differential. So maybe it's actually has more to do with their underlying venous stasis disease. So they're not draining from that area well. So that kind of brings me to my take-home points, which are keep a broad differential for red swollen skin. Non-purulent is most commonly strep, purulent is most commonly staph. But then what I didn't mention in the case, but Bree's question kind of brings up, is at the same time you need to be treating their underlying risk factors and elevate. Elevating is huge. I mean, like prop that leg up on a pillow, get it higher than the heart, if it's on their arm or whatever, you want them to raise it whenever they can, and that will just help drain the blood flow to the area and be very helpful in improving their redness, improving their symptoms, and often the pain as well. So simple stuff like elevating that extremity will be incredibly helpful. All right, moving on to case 3. So this patient presents to clinic with 4 days of headache, nasal congestion, and a pressure feeling over their cheeks. They reported taking ibuprofen once a day for the pain. That hasn't been helpful. They don't have a history of allergies, no recent upper respiratory infection, and no recent fevers. Bringing us to our third poll question. What is your best next step in management for this patient? Thorough physical exam to help distinguish between viral and bacterial causes. The history seemed more viral. I'd recommend symptomatic treatment with scheduled analgesics and saline nasal spray. History seemed more bacterial. I'd prescribe 5 days of amoxicillin clavulanate. Or D, I would start with imaging to gather more information. Okay, a couple more seconds for the last. Yeah, sorry, can I click to the previous slide? Can you read it there? Yeah, so this some days of headache, nasal congestion. All right. Okay, so most common answer, people said that history seems more viral, recommend symptomatic treatment. Then about 40% of people said a thorough physical exam needs help distinguish, and one person said would gather more info. Would get imaging to gather more info. So the answer here, although yes, I'm pro thorough physical exams at all points, but I think this history seems much more viral, even based on that little information that I gave you in the case. And I would recommend symptomatic treatment. So what are we talking about here? We're talking about acute sinusitis. I bring this up because this is a common thing that you're going to see in the outpatient setting, and I want to talk to you guys about when we're using antibiotics for sinusitis and when we're not. And spoiler alert, the vast majority of the time, we should not be prescribing antibiotics here. So for acute sinusitis, you have both viral and bacterial. For viral, the majority of acute sinusitis, over 98%, is viral. 98% of acute sinusitis is viral. I'm saying it again. And treatment for that is supportive. This is a lot of counseling with your patient about expected management and their expected course, right? So it's that their symptoms should resolve or at least be trending towards improvement after a week to 10 days. So it is a long, annoying, slow, miserable process. And that's why people are coming to see you for help. Things that you can help them with: analgesics, saline irrigation and spray, decongestants, nasal steroid, humidifier. Find what works for your patient, make note of it, stick with it, go for it. Bacterial sinusitis is only 0.5% to 2% of episodes. And things that push you towards thinking it's bacterial sinusitis as compared to viral are that it's persistent and not improving. And by that, I mean it's been longer than 10 days. It's severe, which involves people being febrile, having purulent discharge and facial pain longer than 3 days. Or it's worsening, which is, again, newly febrile or they had a URI, improved for a few days, and then got worse after initially improving. So those are things that are going to push you towards thinking that this might be viral. Sorry, those things might be bacterial. So the focus of this case is we're going to talk about that not prescribing antibiotics can be difficult, but you can do it. So there was a recent study that came out this year in CID. There was a chart review of 500 outpatient visits for acute sinusitis, and half of them met IDSA criteria for antibiotic prescription, which were those indications from the previous slide. So persistent, not improving, severe, or worsening. So as you can see, those are pretty generous. With it only being 2% of the causes, those criteria are pretty generous. So they're not going to let you miss folks with those criteria. They're really wanting to screen people into that. So half the folks that met criteria for prescribing antibiotics, 96% of those got antibiotics, but the other half, 92% of those also still got antibiotics. So people were really not using these criteria and were just prescribing antibiotics. I'm going to skip that because I know I want to catch you guys up on some time a little bit. So how do you decrease inappropriate antibiotic prescription? There are a lot of provider-driven ways and also some clinic-driven ways. So you can recognize that your perceptions of your patient's desires may not be accurate. They've studied people, if doctors are perceiving their patients to have wanting antibiotics and then actually interviewing the patients, and providers are perceiving their patients wanting antibiotics way higher than their patients actually want them. Honest communication with your patients that antibiotics do not come without risk. So another question from the chat, different way to differentiate purulent nasal discharge. So that's not by itself, not its own criteria. But I think, you know, we've all had kind of purulent nasal discharge versus kind of clear and otherwise not. So I think anything that is like green, yellow, thick, not translucent would fall under purulent nasal discharge, but that's in conjunction with fevers or worsening pain for several days, for over 3 days in that area. Yeah, yellow boogers from purulence is a bit tough, but I think just talk with them about it, but you want the kind of overall picture. I feel like a vague description of purulent discharge alone isn't going to be enough to push me to prescribe antibiotic for someone. Again, just keeping in mind the 98 to 2% comparison. Then there's clinic-driven ways, and I'll try to skip over those. There have been studies where they've just put up posters like this in the clinic lobby or waiting room, just saying like, we don't use antibiotics, they're not necessary, and providers felt like just having these posters up in the waiting room, they were less likely to prescribe antibiotics. So think about things your clinics can think about. So here are some helpful tips for how to say no. Really just validate their symptoms and provide symptomatic treatment recommendations. So acknowledging that they're miserable. You know, although your symptoms are due to a viral infection that's not going to respond to antibiotics, doesn't mean you're not sick. I'd like to provide you with treatment recommendations that help you feel better while your body's immune system helps fight the virus. So just emphasize you're on their team. You can consider substitution. There are other things you can prescribe that are not antibiotics that could help. Take your time. Point to support. Not everyone's going to know the IDSA, but you know, you can talk about, hey, these are the CDC recommends this for this exact situation. You can share stories that I know so many people who've been treated for upper respiratory illnesses or other viral infections that were given a short course of antibiotics and then came in with C. diff. You know, you don't want that for your patient. And just express concern. We're in this together. I'm on your side. Come up with a follow-up plan. Like, hey, look, this is what we're going to do for the next week. I will call you in a week, or please call me in a week, or let's go ahead and schedule that follow-up appointment. Those kind of things. So just make sure that you can always tweak your plan, you know, if based on that based on how people are doing in that follow-up situation. They just don't want to be cut loose and never seen again. So take homes from this case, acute sinusitis is almost always viral. It's a great opportunity to avoid antibiotics with your patient. Just listen, empathize, educate, and discuss the options with them. Final case, this is very short one. Last poll, what was your role in medical school during the COVID pandemic? Did you get taken off of all patient care duties. Did you help care on the inpatient side, outpatient side, work on research, just catch up on sleep for intern year? Great. So it looks like far and away, most of you were taken off, which I think was the what most folks did. And some people were catching up on screen. Some people were helping screen and test. So that's what this last case is related to. The number of these calls I've gotten has gone way down, but you may in your primary care clinics get this call. Hey doc, I had a bad cold in March and never got tested. It was definitely COVID. Should I get this antibody test? So here I just wanted to go through the two main tests for COVID. You guys are probably all familiar with this now, so I will keep it brief, but there's two nasopharyngeal swabs. There's the routine one, and then there's the rapid test. The only folks who are getting the rapid test are if they're getting admitted. So if you're admitting someone from clinic, you know they're going to need to get a rapid test before they go into the hospital, and that's at all of our hospitals now, including the VA. And these are PCR tests, so they're looking for current infection. Just to note, it can't detect active virus from inactive virus. So that's why these people have been persistently positive for a long time. And the CDC just changed their recommendations that once you test positive, you shouldn't get a repeat test for several months because of this ongoing shedding. We've got drive-by testing sites. Results come back in about a day. It's very sensitive and very specific. Then there's the antibody test. That is looking at IgG in the blood, looking for past infection. There's still a lot of unknowns around this, how long the IgG lasts or if it's really protective. Harborview and UW have kind of looser guidelines for who can send this test. At the VA, it's mostly just for either the patient is saying, my employee needs me to get this antibody test before I go back to work, or I want to be a convalescent serum donor. That's probably going to explode in the news, as you saw that the president announced that yesterday. It has convalescent serums now FDA approved or emergency authorized. So there may be more patients coming to you asking to become a donor. They need an antibiotic test or antibody test. And the main message for your patient is that really regardless of their results, because a lot of these things are still unknown, you should continue all of your social distancing recommendations and your mask wearing and things like that. And there are some great dot phrases in Epic that all start with .COVID-19 if you want to give your patient some more information. John had a question about high-risk exposures. Why do we have to get the rapid test and quarantine for 14 days regardless of results? Doesn't make a lot of sense. Okay, so you're talking on the inpatient side and you're talking about employees who are exposed. I think they're worried about when the test, because if you're exposed, say you were exposed yesterday and you get tested today, that negative test really doesn't mean anything. You could become positive in the next coming days. So the options are what we test you every single day for 14 days or just quarantine. And at this point that's where employee health has come down on that. So they've said, we'll test you, see what it shows. But you know, if you were exposed yesterday, a test today or a test tomorrow, even if negative, doesn't necessarily rule you out as being positive. So that's why those current rules apply. You may have seen the news yesterday and today. In Hong Kong, there was the first patient that has documented reinfection of the virus. It's just interesting to keep in mind. He had a super mild infection and then traveled to Spain, and 4.5 months later developed an asymptomatic repeat infection. They sequenced the viruses and they were different. So this man was reinfected. So I don't think it's a hot topic right now in the news. And I think people are worried about all the implications for the virus, for the vaccine, but I think there's still a lot of hope for the vaccine. And it goes to show a lot of things we've seen with folks who were exposed and had a mild illness right away, don't have a strong of an antibody response. And so their immunity may not be that long lasting. I think we still have good hope for the vaccine because it's going to use a lot of different mechanisms. Take homes for COVID are just low threshold to test for active disease, and the antibody test is up to your discretion and your site's discretion. Just be sure to counsel your patient on the unknowns. So I will leave you here with my take homes. First line for cystitis, nitrofurantoin, trimsulfa with consider fluoroquinolone, then fosfomycin. your MRSA oral antibiotics are trimsulfa, doxy, and linezolid with 50-50 coverage from Clinda. Acute sinusitis is almost always viral. Stay strong when counseling your patients about not needing antibiotics. And we're still learning about this COVID antibody testing. And don't forget, ID is just a quick message away. You can e-consult us at Harborview or UW, or do non-visit consult if you're at the VA. We are happy to answer all kinds of questions. Yeah, and if anyone has questions about ID rotations during residency or questions about ID fellowship down the line, feel free to reach out to me at any point. I am happy to talk with you about any of those things. So happy to take any questions. I think probably get a little break right now before the next speaker. And you can always email me or unmute yourself and ask them now. I'm happy to answer them.
Hey, Michaela, I don't know if you happened to see my question about the saliva direct test.
I did not. Let me scroll back up.
Just before John's.
Oh, yes. Saliva. I have not heard about that here, about implementing it here. But I'm also my research years, so I'm not the most in touch with what the infection prevention folks are doing. I haven't heard though.
Sure.
So.
Any thoughts around it generally, or from what you've seen, or not?
Not at this point. I know it'll be more for like just increasing home testing, and so I'm not sure how much we're going to be using it in the hospital because we have that rapid test that I think the sensitivity is a bit higher on, but I don't have much to say. That's the latest stuff.
Fair enough. Thank you.
Yeah. Whitney says back at 10:05, everybody. Seifu had another question. Is there any situation in which we treat a positive culture in an asymptomatic patient who has a chronic Foley? So that you go by symptoms. So if the patient has a chronic Foley, you want to start by swapping out the Foley because again, the catheter is going to be colonized. So you want to decrease their bacterial burden, so you want to change the Foley. That is step one. And then, but yes, if they're having symptoms of a UTI, even having a chronic Foley, you would still treat. All right, thanks guys.
Thanks, Michaela.
Enjoy your immersion block.